Good morning and a very warm welcome back to the Heart Failure Summit 2023 organized by CSI West Bengal. As we embark our journey for the second day of the conference, we are all set to go, though it's a Sunday morning and we are meeting again post the COVID period tenor on an online conference. But we truly do not care much about the modality of the operation as long as engaging conversation, brainstorming, and learning is concerned. Yesterday, we had an extremely engaging session all throughout the day, and we are absolutely sure that today will also be no way an exception. And we have with us our organizing secretary for the conference, Dr. Shubhra Banerjee, already there, and I can see a lot of panelists and speakers logged in. So without wasting any much time, we will move on to the first session of today. And may I please request our respected chairpersons and panelists to join the session. May I please request our respected chairpersons and panelists, Dr. Shubhanand Roy, Dr. Devanu Ghosh Roy, Dr. Shunil Leela, Dr. Raja Nag, and Dr. Ashok Malpani to begin with the first session of today's conference. And the first speaker for today would be Dr. Gopal Chandra Ghosh. Requesting all the respected chairpersons and the panelists to carry forward from here. Thank you. And with you for the full day, me, Chandrima Roy, I'll be coordinating throughout the different sessions. Happy learning. Stay tuned. Thank you.
Good morning, everybody. And I think today also will be an exciting day of conference. And we start with a very important topic, that is cardiogenic shock. And cardiogenic shock has always been a problem for cardiologist patients presenting to us in cardiogenic shock or patient going into cardiogenic shock after an intervention, and has always been actually challenging clinical condition. So today we are having with us three great speakers who will help us in telling us what are the actually how we manage these patients, and with the recent advances and better intensive care, now many of these patients are actually surviving and mortality has come down markedly. Now to begin the presentation, or before Dr. Gopal Chandra Ghosh starts his presentation, I would just like to briefly mention about the patient that he is going to discuss. It's a 52 years old male patient who has come to the emergency with an acute anterior myocardial infarction. And on examination, he was found to have a cardiogenic shock. The saturation was only 72%. The blood pressure was 80 millimeters systolic, and the heart rate was 130 beats per minute. So Dr. Ghosh will discuss about medical stabilization. Before the patient goes for any type of intervention or anything, what should we do in the intensive care and in the emergency and later in the intensive care, so that these patients can be medically managed. So Dr. Ghosh, you can start, please. We have with us the large number of panelists, and we will discuss about patients after your presentation. Dr. Ghosh, you can start.
First of all, good morning, sir. And good morning, everyone. I'd like to thank Dr. Shubhra Banerjee for inviting me as a speaker. And not only me, inviting all the junior cardiologists, inviting as a speaker here. So today our topic is about medical stabilization, although this topic is looking very easy topic, but we have to manage all the cardiogenic shock patient initially as a medical management. Then we can proceed for further intervention if required. So I just like to show our case. 52-year-old gentleman, diabetic, presented 2 days after then extensive anterior MI. So already 48 hours left. His saturation in the emergency department was 72%. Blood pressure was 80 millimeter mercury, systolic blood pressure, diastolic was not recordable. Heart rate was 130. So before going into detailed discussion, we should rapidly evaluate this patient in the emergency department. We should assess fluid status, lung status, whether lung is dry or wet, periphery is wet or cold. Assessment of the respiration means respiratory pattern, respiratory rate. Immediately do an ECG and X-ray. send some routine blood investigations, uh, put him on oxygen support, given BiPAP, and put an IV central line, do an blood gas, especially lactate blood gas, and do an point of care echocardiography. Just see the LV function and how any complications are there or not. Then admit the patient and send to the high dependency unit. So just to start with few points about cardiogenic shock. Cardiogenic shock is defined as in a condition where systolic blood pressure remains less than 90 or less for more than 30 minutes, or patient is requiring vasopressor support to maintain the blood pressure, systolic blood pressure more than or equal to 90 millimeter mercury, with evidence of some end organ damage like urine output less than 30 ml per hour, full extremity, and there are some hemodynamic criteria like cardiac index less than 2.2 liter per minute with pulmonary capillary wedge pressure of 15 millimeter mercury. So just going into the few points regarding the pathophysiology, the main important points are issue is hypotension and hypoperfusion of the tissue. So in normal coronaries, the flow is regulated mainly by the microvascular resistance, and coronary flow remain preserved up to the aortic pressure of 50 millimeter mercury. In patients with critical stenosis in the coronary artery, the vasodilator reserve of the microvascular bed is exhausted, and that leads to coronary hypoperfusion and repeated ischemia. A normal heart can extract 65% of the oxygen present in the blood, but in the presence of cardiogenic shock, there is little room for augmentation of the oxygen extraction. And not only the hypotension, but also increase in the LV and diastolic pressure. The increase in the LV and diastolic pressure further impairs the coronary flow, and that causes coronary ischemia. As you can see from this graph, the blood flow at the LV and diastolic pressure 5 is, you can see, up to coronary flow is 250 ml per minute. But if the LV and diastolic pressure is 30, the flow comes down less than 100. So if in presence of critical ischemia in the coronary artery, there is significant uh, coronary ischemia. And ultimately, not only this hypotension and hypoperfusion, but also there is a large MI. If you see the cardiogenic shock patient in the presence of MI, almost 50% of the myocardium is already damaged. And this damaged myocardium initiates some inflammatory changes. So combination of this ischemia and inflammation ultimately leads to organ decrease in the organ perfusion, increased volume overload, drop in the cardiac output, and multi-organ dysfunction, and ultimately death. There is some now how to categorize the therapies in cardiogenic shock. There is a Society of Cardiovascular Angiography and Intervention classification of stages of shock. So there are 5 stages: A, B, C, D, E. A and B. A, you can see pre-shock state. B is early shock. C is definite shock. D is advanced shock, and E is non-reproducible condition. So in A and B, the blood pressure usually maintained around 90 with minimal inotropic support. The lactate is normal. There is minimal creps in the lungs. C is the classical shock, where you need good amount of inotropic to maintain blood pressure. Lactate is more than 2, and there is elevated BNP, urine output drop, and patient is little bit drowsy. Patient is in class 3 or 4 heart failure. D means advanced stage, and E means you cannot repair the condition. So the medical therapy is very much effective in stage A and stage B. So definitely in stage A and B, with minimal medical stabilization, you can proceed for coronary vascularization. But once patient has gone into C or D, you have to medically stabilize him, and then you can consider for mechanical circulatory support and decide on revascularization or not. E, we have to give palliative support, not more than that. Now, for medical management, most important aspect is the vasoactive agent. So more than 95% situation, we need some vasoactive agents. Vasoactive agent can be categorized as vasopressors or inotropic agents. Vasopressors like norepinephrine, epinephrine, dopamine, and vasopressin. Inotropic agents, mainly the inodilators, are dobutamine and milrinone. Levosimendan is also effective in some situation, but and they are not classically used in cardiogenic shock. So if you see the different vasoactive agent, not a single agent, we can tell that this is a class 1 agent and we can use only that. So you have to decide depending on the patient volume status, patient lung condition, patient blood pressure and all. So dobutamine and uh, milrinone, these two are ionodilators. They increase the contractility and they decrease the systemic vascular resistance. Otherwise, the norepinephrine, epinephrine, and vasopressin, they are purely vasopressors. So this is a very classical chart. In two axes, you can see the phenylephrine, vasopressin, and nitroprusside. They are mainly vasoconstrictor or vasodilator. They act only in this pathway. But uh, dopamine, norepinephrine, and epinephrine, dobutamine, milrinone, they have both effect as a vasoconstrictor and they also increase the contractility of the heart. So they have positive inotropic effect. So few points about the vasoactive agents. The optimal choice of vasoactive agent in cardiogenic shock is still unclear. More than 90% cases, we need some vasopressor. Norepinephrine is preferred over dopamine in patients with significant hypotension, means systolic blood pressure less than 70, because dopamine increases the risk of arrhythmia and death in that situation. With mechanisms of action independent of the beta adrenergic receptor, milrinone and levosimendan may be considered as to increase cardiac output, especially in patients treated with beta blockers. Thrombolysis has classically no role at present scenario, but in peripheral situation where you don't have access to cath lab with immediate shifting, you can still try if the patient have ongoing ischemia or uh, chest pain. Other therapeutic options are fluids. Sometimes patient comes with recurrent vomiting, hypovolemic state also. In that situation, we need to keep some volume also. So ringer lactate solution is ideal for that. Therapeutic hypothermia in cases out of hospital cardiac arrest, where they have brought the patient to the emergency department. You can try this also. But we have to give diuretics. Diuretics has important role to relieve systemic and pulmonary congestion. So coming back to our patient is in stage B or C cardiogenic shock. So he needs medical stabilization before sending him to cath lab. So my preference will be to start noradrenaline plus dobutamine. So many a times we can combine two vasoactive agent, and noradrenaline with dobutamine is a very good combination. So noradrenaline increases the systemic vascular resistance, dobutamine decreases or keeps same. Dobutamine has effect on pulmonary capillary wedge pressure. Dobutamine decreases the pulmonary capillary wedge pressure. So our patient has lung congestion, so we can combine these two molecules. So give him BiPAPs, give some IV diuretics, stabilize him, then decide on the further plan. So my take home will be even in current scenario, there is very high mortality condition. The recent trials showing the mortality rate is almost 50%. And timely initiation of treatment is of utmost importance. Our patient is already delayed for 48 hours. So prognosis is relatively grave. So the concept of early initiation of treatment, whatever, that may be the medical management, or that may be the revascularization plan, that should be very early. And almost all patients with cardiogenic shock need some kind of medical stabilization before intervention, as our panelist already told. Thank you. Thank you. Now the topic is open to the panelists for discussion.
We will take all the discussion at the end after the three speakers have given their deliberations.
Sure, sir.
At the end only. Okay.
Yeah.
So the next speaker, Shwarnandra is here. Has he joined?
I'm here only.
Yeah, you can please start. I forgot.
Okay, you can start. There is no problem. Absolutely. I'll be always there. No problem.
Okay, so now this patient has been, as we have seen, has been very nicely managed by Dr. Gopal Chandra, and he has given a very nice practical demonstration of how to manage these patients. I think that was very, very good. I must appreciate it.